Restless leg syndrome, the most common condition you've never heard of. www.rls.org. RLS excludes PLMD. RLS includes PLMS. Definitions: RLS equals restless leg syndrome. PLM equals periodic limb movements. PLMS equals PLM in sleep, characteristic movement that occur during sleep. PLMW equals PLM in wake, usually seen as part of a nocturnal PSG. PLMD equals PLM disorder, a sleep disorder based on a finding of PLMS, usually less than 5 per hour of sleep, with an associated sleep dysfunction that cannot be otherwise explained. Historical references for RLS. Therefore, to some, on being abed, they betake themselves to sleep, presently in the arms and legs, leaping and contractions of the tendons, and so greater restlessness and tossing of their members ensue that the diseased are no more able to sleep than if they were in the place of the greatest torture. Willis T. The London Practice of Physic, London, Bassett and Crook, 1685. Historical references. Whitmer Active Pathologie und Therapie der Sensibilität Neurosen, Leipzig, Schaeffer, 1861. Anxietas tibiarum, felt to be of hysterical origin. Ikbom K. Acta Mediscand. 1944 118 to 197 to 209. Asthenia crurum paresthetica, irritable legs. Common characteristics of restless leg syndrome. Unpleasant sensations in the legs, sometimes the arms as well. Often described as creeping, crawling, tingling, pulling, or rarely painful. Leg sensations are relieved by walking, stretching, knee bends, massage, or hot or cold baths. Leg discomfort occurs when lying down or sitting for prolonged periods of time. Common characteristics of restless leg syndrome. The symptoms are worse in the evening and during the night. Involuntary leg, and occasionally arm, movements while asleep. Difficulty falling asleep or staying asleep. Sleepiness or fatigue during the daytime. Cause of discomfort not detected by medical tests. Family members with similar symptoms. Terms used to describe RLS sensations. Primary features of RLS essential for diagnosis. A sensation of an urge to move the limbs, usually legs, accompanied by uncomfortable or unpleasant sensation. Motor restlessness to reduce sensation. Onset or worsening of symptoms when at rest. Marked circadian variation in occurrence or severity of symptoms, nighttime. No other identifiable cause. SleepMed 2003, 4, 101-19. Symptoms of RLS follow circadian rhythm. Henning W. et al., Sleep 22, 901, 915, 1999. Associated features: periodic limb movements in sleep. Sleep disturbance, especially difficulty in sleep initiation. Positive family history. Onset at any age. Chronic and progressive course with remissions. RLS severity scale: 10 questions specific to leg discomfort, movement. Effects on sleep. Overall quality of life. 0 to 4 rating of various symptoms for each question. 0 equals none, 4 equals very severe. 0 to 10 mild, 11 to 20 moderate. 21 to 30 severe, 31 to 40 very severe. Distribution of RLS scores. Neurology 2005 65 to 239 to 246. Differential diagnosis of RLS. Leg cramps. Peripheral neuropathy. Varicose veins. Intermittent claudication. Neuroleptic-induced akathisia, symptomatic restless legs. Iron deficiency. Hemoglobin normal but low ferritin. Uremia, caffeine, nicotine. Diabetes. Peripheral neuropathy or radiculopathy. Fibromyalgia. Rheumatoid arthritis. Pregnancy. Vitamin D deficiency. RLS epidemiology affects 5 to 10% of population. Increased in French Canadians, Levine G. and Montplaisir J. Sleep 1994, 17 to 739 to 43. Prevalence increase with age. Women more affected than men. RLS prevalence in France N equals 10,263. Neurology 2005 65 to 239 to 246. RLS prevalence in France N equals 10,263. Men. Women. Prevalence in Germany N equals 431. Arch Intern Med 2004, 164, 196 to 202. Symptoms in a U.S. population. Arch Intern Med 2000, 160, 2137 to 41. Genetics of Restless Leg Syndrome. Familial nature first described by Eichbaum. Complex inheritance. 3 major loci identified. 12q, French-Canadian. 14q, Italian, Canadian. 9p, 2 U.S. families. RLS pathophysiology central nervous system dysfunction. Cortical. Subcortical. Spinal cord. Brain dopaminergic function. Iron metabolism. Iron dopamine model of ILS. Brain iron insufficiency. Restless leg syndrome. SNES dopamine abnormalities. Ferritin levels correlate with RLS but not PLMS. Iron dopamine model of ILS. Control. RLS. Early CJ et al. Neurology 2000, 54, 1698 to 1700, MRI measurement of brain iron in RLS patients. Iron content is reduced in both red nucleus and substantia nigra for RLS patients compared to controls. Allen R.P. et al., Neurology 2001 56 to 263 to 65. Impaired brain iron acquisition in restless leg syndrome, neuropathologic examination. Marked reduction in ferritin in substantia nigra of RLS brain. Control. RLS. Neurology 2003 61 to 304 to 309. 5 seconds. 15 seconds. 30 seconds. Periodic limb movements. Characteristic limb movements. 0.5 to 10 seconds duration movements. Recur periodically, every 4 to 90 seconds. Must occur in a series of 4 or more in any sleep-awake state. Diagnosis of PLMD with the above and greater than 5 hours in children, greater than 15/H in adults. Clinical sleep disturbance or daytime fatigue. Not better explained by another disorder. Cannot diagnose RLS and PLMD at same time, ICSD. Disease of conditions associated with PLMS. Narcolepsy. REM sleep behavior disorder. Neurodegenerative disorders. Tourette's syndrome. Peripheral neuropathy. End-stage renal disease. Pregnancy. Post-traumatic stress disorder. Obstructive sleep apnea. Antidepressants, exceptions, bupropion trazodone. Periodic limb movement syndrome. Most people are asymptomatic. Poor association between PLMS and sleepiness. 1/3 of patients with PLMS have RLS. Needs PSG for diagnosis. Treatment of RLS and PLMS varies according to the clinical course. Comorbid medical conditions. Presence or absence of associated pain. Individualized therapy, pharmacologic Rx for RLS. dopamine receptor agonists and dopamine precursors, opioids, benzodiazepines, anticonvulsants, other pharmacologic Rx for RLS. Iron supplements as Rx for RLS. Check serum ferritin levels. Add iron in patients with serum ferritin less than 50 mg/L. Ideal supplement not known. May take several months to be effective. May be poorly tolerated. Vitamin D deficiency is associated with restless leg syndrome. Vitamin D deficiency is associated with restless leg syndrome. Ayman Krayam, FCCP, Surajwali, FCCP, Afnan Shukr, MBBS, Ayabudal, MBBS, Ahmed Al-Siari, MBBS. Abstract, poster number 704. American Academy of Sleep Medicine Annual Meeting, June 1 to 5, 2013, Biltmore, USA. Manifestations of augmentation. Increase in RLS symptom severity during treatment. Frequency of symptoms or earlier symptoms. Duration of symptoms. Number of body parts affected. Intensity. Most commonly during treatment with L-DOPA and estimated to occur in 27 to 82% of cases. Not reported during treatment with opiates, anticonvulsants or other dopaminergic drugs. Conclusion: RLS is common but underdiagnosed. Consequences: insomnia, bed partners separation, depression and sexual dysfunction. Diagnosis, history. Workup: iron, vitamin D, folic acid, vitamin B12. Management, replacement, specific drug therapy, dopaminergic.